Thanks very much. I'd like to thank the organizers for asking me to speak to you today. Let's consider positioning long-acting antiretroviral therapy in lower and middle income countries. I have no disclosures. I am the co-chair of the US DHHS Adult and Adolescent ART Treatment Guidelines panel. So today in 2021, we have a total of 33 drugs approved for the treatment of HIV. And the most recent drug to be approved is a long-acting agent. WHO recommendations for first-line ART regimens for adults in lower and middle income countries are well known to you. The preferred regimen is dolutegravir and nucleosides. And as you know, that can be available in a one pill once a day regimen. The alternative also, efavirenz with nucleosides, and that too, one pill once a day. Well, can we do better? What are the options for longer acting drugs? Well, the newest drug to be approved is a long-acting agent, cabotegravir. Cabotegravir is an integrase inhibitor that's similar to dolutegravir and has a similar resistance profile. We know from studies a few years ago that it is potent in people living with HIV, and oral doses have been tested and correlate with an antiretroviral effect. However, the excitement about this compound is its use of a nanotechnology formulation. So subcutaneous and intramuscular injections are available with this compound, and it has a long half-life of 21 to 50 days. Well, that supports monthly, bi-monthly, or even less frequent dosing of this drug. So truly a long-acting agent. Now, an injectable can be associated with injection site reactions, although these are mostly mild, and even nodules with subcutaneous dosing. Again, these were described to be mild. We now have phase 1, 2, and 3 studies completed for cabotegravir in treatment regimens. This slide summarizes the recently completed phase 3 studies. The first was called FLAIR, published in the New England Journal. It enrolled treatment-naive individuals, 629, put them on an oral regimen of abacavir, 3-TC, and dolutegravir for 20 weeks. And then, if suppressed, they were randomized to switch to an all-injectable regimen of cabotegravir and an injectable form of the non-nucleoside rilpivirine. And that was given on a monthly basis, or the other half of the patients were randomized to continue the one pill once a day oral regimen. And this was a non-inferiority study with a non-inferiority margin of 6%. The 48-week results as published showed virologic suppression in over 93% of all participants. And they concluded that cab and rilpivirine, the all-injectable regimen, was non-inferior to the oral regimen. They recently updated these results at the Glasgow meeting with 3 years of data. A parallel study was called ATLAS, also published in the New England Journal last year. This enrolled adults who already had virologic suppression on standard regimens of 2 nucleosides with either a protease inhibitor, a non-nucleoside, or an integrase inhibitor, and they enrolled over 600 people. They were randomized to either continue their oral regimen or change to the injectable regimen of cabotegravir plus rilpivirine, and these were given monthly. Again, this was a non-inferiority study with a margin of 6%. Once again, the results at 48 weeks showed virologic suppression in over 92% of all people enrolled on the study, and the investigators concluded that the injectable regimen was non-inferior to the oral regimen, and they recently updated at Glasgow with 2-year results. Well, once a month injectables are now shown in these 2 studies. Another study called Atlas 2M, recently published in The Lancet, looked at a different scheme. So they enrolled adults on standard of care ART regimens or cabotegravir plus rilpivirine long-acting given monthly, And all the patients were required to have virologic suppression to less than 50. And you can see they enrolled over 1,000 people. They were randomized to receive the injectable regimen either every 4 weeks, as had been done in the prior studies, or every 8 weeks. And this too was a non-inferiority study with an even tighter margin of 4%. 48-week results published showed that 93% of all people were virologically suppressed, and they concluded that the every 8-week all-injectable regimen was non-inferior to the every 4-week. And they recently updated these results with 2-year results at the CROI meeting. So where are we? Well, 16 countries were represented in these studies, and they included high-income countries, but also middle-income countries like Argentina, Mexico, and South Africa. And these constituted the data that led to regulatory approval, first in Canada, then with the European Medicines Association in 2020, and subsequently earlier this year in the United States and Australia. So increasingly, this all-injectable regimen is available. Well, what are some considerations for the all-injectable regimen? The loading dose is CAB-LA, that's long-acting, at 600 milligrams, and rilpivirine long-acting at 900 milligrams. These are 3 ml injections and need to be done at 2 different sites, most often 1 in each buttock. The monthly maintenance dose is a bit lower, CAB at 400 and rilpivirine at 600. These are 2 milliliter injections, again, that need to be done at different sites. Rilpivirine does require cold chain storage, refrigeration at 2 to 8 degrees Celsius. And the injection is into the gluteus medius. If you remember from anatomy, that's the upper outer quadrant of the buttock. And again, 2 shots would mean doing 1 on each side. And this can be complicated. One needs a private place for injections, perhaps a longer needle for people with obesity, and some people with buttock implants may complicate where you inject these agents. The US DHHS guidelines just came out with guidelines for injectable CAB and rilpivirine, requiring people to have documented virologic suppression on ART for at least 3 months, as was done in the phase 3 studies. No baseline resistance to either cabotegravir or NNRTIs, no prior virologic failure, no active hepatitis B, because these agents are not active against hepatitis B, unless they're on an orally active HBV regimen, not pregnant and not planning on becoming pregnant, not receiving medications with significant drug-drug interactions with either cabotegravir or rilpivirine. And 2 common examples would be rifampin and rifabutin. And they do recommend that they should receive oral cabotegravir with oral rilpivirine for 28 days as an oral lead-in to assess tolerance before initiation of IM injections. Clearly, there are a lot of requirements. Well, who are the appropriate candidates for an all-injectable regimen? There was a presentation at IAS 2020 that actually surveyed study staff at some of the sites that were doing these studies. And they did these surveys both baseline and 4 months into CAB rilpivirine implementation. They identified the top 5 characteristics of appropriate candidates for long-acting therapies. People tired of taking pills, people concerned about HIV disclosure, people stressed about adherence to a daily oral medication, people who feel stigmatized by HIV, however, people adherent to oral antiretroviral therapy. Note that the group missing here are people with adherence issues. We tend to want to use a long-acting agent in that group, but they've really not been studied with CAB rilpivirine. Some studies are in progress. Well, they also did a survey of what were the barriers, and you can see that these constitute a common theme. Patients' ability to keep monthly appointments, transportation, what do you do about missed injection visits? What about clinic flow, rescheduling missed injections, failing to show? So kind of a common theme was, what do you do about missed injections? Well, the package insert helps us. This is from the US FDA cabotegravir rilpivirine package insert. And they say adherence to monthly injection dosing schedule is strongly recommended. If there are planned missed injections greater than 7 days, then start oral cabotegravir plus rilpivirine 1 month after the last injection and continue until the day injections are restarted. So one could plan to miss an injection, for example, for travel or hospitalization. Unplanned missed injections are more complicated. The first point in the package insert is to reassess the patient to determine if resumption of the injection dosing remains appropriate. If it's less than or equal to 2 months, then resume monthly injections with the standard dose. However, if it's been more than 2 months, then reinitiate with a loading dose at the higher dose of cab and rilpivirine, and then transition a month later to the lower maintenance dose of cab plus rilpivirine. There are other long-acting drugs in the pipeline. Islatravir is a nucleoside analog with a long half-life, and this could support oral weekly dosing. MK8507 is a non-nucleoside. It too has a long half-life, and it too could be part of a regimen with oral weekly dosing. So imagine using a combination of agents where one only had to take meds once a week, say every Sunday. Some people might prefer that. Lenacapavir is an example of a drug with a new mechanism of action, capsid inhibitor. It too has a long half-life, 30 to 43 days, and is available in a subcutaneous formulation. This can be given every 2 weeks, or with an enhanced formulation, even 6-month dosing is possible. Let's take a deeper look. So islatravir is an investigational nucleoside reverse transcriptase translocation inhibitor. It's an adenosine analog with a long half-life, as mentioned. It has potent antiretroviral activity and broad coverage against HIV 1, 2, and multi-drug resistant strains. It's available both in low dose and parenteral formulations. Phase 1 data with a single dose led to virologic suppression on the order of 2 logs out to 10 days later. This, again, supports once-weekly oral regimens with islatravir. Other studies have been done in combination with daily dosing and recently published. MK8507 is an investigational non-nucleoside, potent in the test tube and active against common NNRTI-resistant strains. The half-life is long at about 70 hours, and a phase 1 study showed potent antiviral activity at the doses tested. So single doses, again, led to 1.5 log or greater suppression in the study. The conclusion was that this too could support once weekly dosing of this agent. And finally, lenacapavir, the investigational capsid inhibitor, is highly potent in the test tube in vitro, active against all tested subtypes, and has decreased clearance and solubility, leading to a prolonged half-life. It's available in oral and subcutaneous formulations. A single subcutaneous dose led to potent virologic suppression at the highest dose tested, again, about a 2-log drop 9 days after dosing. There's a newer formulation with an even longer half-life. This too is given subcutaneously. What's shown for you here are 3 doses and drug levels. The target level is the horizontal line, and you can see the 2 highest doses actually achieved that 6 months later. So this could be a subcutaneous 6-month dosed drug. Phase 2 and 3 studies are in progress. Lastly, there are 2 different ways that one could give long-acting agents. Islatravir, the nucleoside analog already mentioned, could be part of an implant, similar to a contraceptive implant. We saw the first human data presented at last year's IAS and this year's CROI double-blind placebo-controlled multi-site in HIV-negative people. And this was looking at 3 doses of the compound and looking at drug levels. And as you can see, all 3 doses led to levels. The horizontal line, again, is the target level. And you can see up to 12 weeks later, the 2 highest doses were well above the target level. They used this to model and found at the highest level tested that you could actually have target levels for over a year. So could we have an antiretroviral implant that only needed to be replaced once a year? And then lastly, what about a patch? So cabotegravir is being explored with a patch that would give the drug. It looks kind of thorny here, but actually these don't reach the nerve, so you don't feel the patch when it's put on. This is in its beginning development, but what you can see here is pharmacokinetic data that tested patches giving cabotegravir compared to the horizontal line, which was oral dosing. You can see at the higher levels, every 28 days that the patch actually achieved these levels. So could we have a patch antiretroviral therapy? Well, something to think about. Long-acting antiretrovirals, in conclusion, current first-line recommended ART, as you know, is an oral single tablet 2 or 3 drug regimen throughout the world. But the first all-injectable long-acting ART regimen, cabotegravir plus rilpivirine, demonstrated non-inferiority to an oral regimen and recently received regulatory approvals and is becoming increasingly available. Other long-acting ART regimens are under investigation. Those could be weekly oral pill regimens or every 2 weeks to 6 months subcutaneous dosing, and then newer formulations like implants and patches. Long-acting ART, in conclusion, will offer choices to our patients and hopefully promote adherence long-term. And I'll stop there and thank you for your attention.